Thank you so much, Angie. So today we are talking about, let me make sure you all can see my screen here. So today we're going to be talking all about what I'm titling this as women's hormone homeostasis. So we're talking not just about the levels of hormones, but also, how do we keep that term that gets thrown out all of the time, hormone balance. What actually is that, and how do we obtain that? So we'll be talking about this through testing, but also treatment and lifestyle solutions. So whether you are wanting to use hormone replacement, bioidentical, or otherwise, or even botanicals and nutraceuticals and things like that, everything will be covered, hopefully, in this kind of broad sweep. So we will talk about the major hormones, but also their pertinent metabolites from those parent hormones. We'll talk about different types of testing methodologies, and I will do my best to do a graceful sweep of all ages of women. So whether we're talking about premenopause, menopause, or postmenopause, and the most common issues that we have within those age ranges. We'll talk about botanical, nutritional, and lifestyle support. So hopefully, no matter what type of practice you're involved in, you'll have some great clinical pearls to leave with. I do want to mention some of the hormone controversy that's out there and help us to get a better understanding of why that is, and maybe a decent discussion about that and whether hormones are safe or not. Predict how tachyphylaxis relates to hormone replacement. I really want to focus on that because I think it's not something that is talked about a lot. And I think a lot of patients tend to get given doses of hormones that are higher than physiologic levels. And we'll talk about, what that is doing to the body and how that might complicate things. And then we're going to discuss a brand new study about HRT past the age of 65, which I think is really exciting and puts to rest a huge question that we've all had for a long time is, do we continue hormones indefinitely, or do we need to stop at a certain age? A lot of times physicians are taught to stop at the age of 65. So we'll talk about that. So these are the major hormones we're talking about today: estrogen, progesterone, testosterone, DHEA, and cortisol. Cortisol, I won't go into a massive amount of detail in today's lecture. We did have an entire Wellness Wednesday dedicated to that earlier this year. So if you want to go and view that, you certainly can on the Doctor's Data website. All of the hormones are interconnected, and we can see that here in this steroid hormone cascade. I know if you are my age, you put your readers on and you zoom in here and take a peek at all of the parent hormones, which are highlighted in blue. So you have progesterone, testosterone right here, estrone, estradiol, estriol, and then we have cortisol as well. Everything that is highlighted in yellow are the hormones that you can get through the HUMAP test, which is the urine metabolites. So the blue would be like a salivary test, or your standard serum test would provide that as well. And then yellow for the urinary test. So certainly this is always going to be our goal, is to help a woman of any age range, right? Premenopausal, perimenopausal, and postmenopausal. And our job is first to understand symptoms. After that, we're then getting a pertinent history, doing a physical exam, following that up with testing. And then, of course, we have treatment and follow-up. Now, this sounds super easy when you lay it out on a slide like this, right? But we know it can get really nuanced. So I'm hoping that this hormone symptom key and a few questionnaires that I will show you will help you clinically. So I've used this for years, and basically I have this kind of at my right-hand side. It's mostly in my brain at this point, but if you have patients and you maybe want to ask them these questions or have them fill this out and bubble it in, this will give you a broad idea of how to get started and how to help them. So we've color-coded the different symptoms with the most well-connected hormone insufficiency. So there is certainly crossover. We know that the human body is never going to put things in a nice, tidy box with a bow for us. But this is a great starting point, and I find that it does really help. And also, when I'm talking to a patient, this is really helpful because they can start to see, oh, I get it. Thank you so much for telling me that these symptoms are related to low androgens. That makes so much sense to me, right? And it really helps them to be motivated and to have a lot of trust in your knowledge and what you're doing. There are many different intake forms that you can find out there on the internet, but I really like this one. This is from the North American Menopause Society. You can find it at menopause.org. And this is specific for menopause. It's an intake questionnaire that's very thorough. And I do find it's really a great one. So if you want to download this and use some of those as an intake form, I think that would be a really good idea. And again, of course, you'd be using a slightly different form for your younger women, but this would work really well for perimenopause and menopause. And then we have our physical exam. You don't need to do all of the things that are listed on this slide, of course, but these are probably, it's the list that you want to kind of run your brain back over every single time you're seeing someone, if these are appropriate. So, if we're talking about somebody 40 and older, a mammogram, potentially osteoporosis screening or colorectal cancer screening. And then, some of the more common things in every single patient, and then your younger patients as well. So have that kind of at your right-hand side and go and review that from time to time. Make sure you're getting all of those touch points. So this is hormone homeostasis, right? We care what is the level of hormone? Do we have too much or too little? But we also care, what is that hormone doing once it's inside the body? Is there activity of that? Meaning, is that hormone getting through the cellular membrane? Is the cellular membrane healthy enough? And then is it getting to the receptor site within the nucleus? And is it turning on that DNA nucleus and having an action in the body? That is truly not able to be tested, but we can potentially think theoretically through the health of those cells, the health of the receptor sites. And so I think what I want to emphasize here is that the hormone level does matter, but that's only part of the equation. How much hormone do we have? What is that receptor site doing? How is the metabolism of that hormone proceeding through the body? There's a circadian rhythm and a pulsatile nature to hormones, sex hormones specifically. We have a 28-day kind of movement, and we also have a daily rhythm. And these hormones are never staying at one point, right? The body is so beautifully attuned to this pulsatile nature that if we are coming in with hormone replacement, it's probably a good idea that we at least attempt to mimic that in some degree. And so honoring that will bring hormone homeostasis or hormone balance, which is what we're all looking for, right, for our patients. And then we have these items that can really throw the hormones off balance or basically hijack the whole situation that we're trying to get after. And those would be things like inflammation, stress, poor sleep, poor nutrition. Endocrine disruptors are probably the biggest thing that I'd like to highlight today and talk about in some detail. I think this is more than we would like to acknowledge, and just kind of a frustration of everyday life is that we are all bombarded with these endocrine disruptors. So we have to be quite active at trying to help patients get through that as best we can. And then again, as I mentioned, the cellular membrane, that's the brain of the cell, and that has to be healthy in order for things to transit back and forth through the cell. So as far as testing considerations, if you're testing in serum, generally in a lot of patients, I'm looking also at thyroid panels because thyroid will overlap so much with sex hormones that I tend to use that as a screening for most of my patients. CBC and a CMP. Looking at ferritin levels is also important. When those iron levels start to drop off, that can also mimic a lot of symptoms that we might be thinking of for hormones as well. Vitamin D levels are also important. You'll see in insulin resistance, those can play a big role. And then lipid testing to look for general health markers. So this is probably an overwhelming slide, so I apologize about this, but I created this to show you my thought process of how I choose the testing medium that I'm using, and then how I use additional testing after that, and how I decide whether to go with, nutrients or botanicals, and then choosing hormone replacement as well. So I probably should have put this slide at the very end of the lecture so that when we talk through some of this stuff, it'll make a little bit more sense. But do keep this in mind, and you can maybe go back to it and kind of study that and see if this is aligning with how you practice. But I generally am choosing saliva and urine testing. Saliva and urine testing are quite different than each other, so I will sometimes use them together. Saliva is more, hey, how much do we have at the tissue site within the body? And then urine is telling me how that's breaking down and how it's leaving the body. I tend not to use serum a lot unless, I have no other choice, basically. And that may be the case for you, and that's totally fine. I think you can still be successful if you're using serum testing. I would highly recommend that you're not using serum testing to decide or to change or adjust dosages, especially if we're talking about topically delivered or transdermal hormones. So if you're doing topical estrogen, topical progesterone, topical testosterone, you're going to be very easily overdosing that patient if you're using the serum to help guide that. There's a whole lecture about all of this that I did back in January, so you can go and check that out. It's another Wellness Wednesday. So not to kind of blow over that, but it's a big discussion. So as a baseline test, I think the comprehensive panel is a really great starting point for saliva testing. There is a comprehensive plus panel that's the same hormones, but we're adding estrone and estriol to give a more complete estrogen look. And then with the HUMAP, that's that liquid urine hormone metabolite. So I oftentimes find that's a great, ideally, this would be a fabulous addition. You'd have saliva and urine together. And that's looking at, how much is in the body, how much is leaving the body, and which direction. With hormone testing, you're assessing very different items than you are with saliva testing. You're looking at both the endogenous and the exogenous metabolism, the risk associations associated with some of those metabolites, and you're really getting a great understanding of phase 1 and phase 2 estrogen detoxification, as well as the enzymes. So the enzymes are key in that urine testing. You can really get a sense and pinpoint different enzymes that you might want to upregulate or downregulate. And this is, there's some argument for not doing testing and going off of symptoms, which I think is fair. And I understand how that determination happened if we're using serum testing mostly. But I do find that, especially with menopause and even perimenopause, even premenopause, you have 3 different patients with 3 different variations of symptoms. But they can look very similar, right? They can all have the same degree of symptoms, to different degrees. But what you'll find, and this is patient 1, 2, and 3, is that their testing levels, these are saliva tests, look quite different. So this is why I'm a huge proponent of testing. So I feel like when I'm moving forward in treatment, I'm not guessing that I actually have subjective symptoms, but I'm matching that with objective test markers. As you know, and as you're very, very familiar with, the hormone symptoms can be so broad, somewhat vague. They overlap so much with other types of pathologies, thyroid, low iron, for instance, other autoimmune conditions potentially, and stress. I mean, stress is cannot be overlooked as such a massive player in all of this. And so I just find I feel much more comfortable if I have solid numbers. I think one of the areas where this gets most relevant is when you have a woman who even late perimenopause or postmenopause, you would expect to have low estrogen. Maybe she's having hot flashes and night sweats, but you actually, upon testing, can see that her estrogen level is perfectly fine, or even on the high end of normal, even high. And this is because of aromatization and metabolic syndrome, insulin resistance, all of that. And, honestly, that's quite common in today's world. And so I want to make sure, hey, if she's having hot flashes and night sweats, I'm going to address some of that aromatization and try to bring that insulin resistance down rather than just throwing estrogen at it. I'm going to make sure that I'm being well-rounded and not missing that cardiovascular risk potentially that's there, and using testing to help guide me with that. So the timing of the testing is important. For premenopausal women who have 28-day cycles. Usually you're looking at having them collect somewhere between day 19 and 23. And this would be true whether you're testing in saliva, urine, or serum. But this is specifically written for saliva and urine testing. And then if you have those perimenopausal women that are just, there's no rhyme or reason and you're having a really hard time helping to time that test, this slide will help you do that. It will help give you options for, if there's any sign of ovulation, you can use that. If not, you can still have some help in determining when you should do that. Postmenopausally, they can test at any time. It really doesn't matter. And this is why we're trying to time it correctly, is because the reference ranges are really based on that mid-luteal phase. So we're looking at the estrogen peaking for that second half of the cycle, and then the progesterone peaking for the entire cycle. We're trying to capture to see, how those levels are reaching. If you see progesterone that's lower than expected, and estrogen is within range or even low, oftentimes you can say, hey, ovulation very likely did not occur during this cycle. That was maybe an anovulatory cycle, or this patient is not ovulating at all. Okay, so that's why that can be so helpful. And then as far as the urinary metabolites, we're looking at different things here, not how much hormone is in the body, but how is it leaving and how is it breaking down, what direction. And that can give you information about carcinogenic potential. We have research to indicate some of those things. And then we can also look at methylation potential. How well is that COMT or COMT enzyme working? And we can see that in real time. It's not a genetic test where we're saying, hey, you have, this DNA sequence. We're saying, hey, this is what it's actually doing in a functional way, and be able to glean some information on that. We can look at phase 1 and phase 2 detoxification. We can look at progesterone and its metabolites, including looking at allopregnenolone. So we can test allopregnenolone directly. We can test progesterone directly. We're not adding together the metabolites to give you a total progesterone. We're actually getting a value of progesterone in this test. And then androgen metabolism. This can help evaluate PCOS or metabolic syndrome. We can look at, again, the enzyme activity like aromatase or 5-alpha reductase. Those two enzymes can cause a lot of havoc to health. And if we can see how robustly they're working, we can work to either calm those down and mitigate some of that risk. And then cortisol metabolism can help give us information about obesity or metabolic syndrome, inflammation, and thyroid health. And this is what that HUMAP test looks like. This is the first page of it. It's beautiful and color-coded, and I love it so much. But this would be a great addition to, say, salivary testing. Some of you are very comfortable with urinary testing and you use that solely, and so certainly you can do that here. The way that I think through this and the way that I would recommend you do it is thinking about saliva as, that starting point. Does my patient have enough or too much hormone to begin with? And then urinary testing is telling me how is that moving through and out of the body, and how, what pattern is that happening in? And if you have, both of those things happening at the same time, I like to think of that as like a really healthy garden. You have the soil, the nutrients, and those are all breaking down accordingly. Your patient is going to be very healthy at that time. There are other types of tests that you might want to consider adding or thinking about in addition to hormone testing when you are working to improve hormone health, and one of which is neurotransmitter testing in the urine. This can be done, and this can actually be added on, say you're doing HUMAP and you're doing urinary testing. You can actually add this test on to that same sample, so the patient doesn't even need to collect anything additional, which is really nice. But this is looking at things like serotonin and GABA and dopamine. And as we know, the body being so complex, these hormones are interacting with neurotransmitters and different types of systems in the body. So this can help actually give us information about some of the symptoms as well in hormones. Specifically, think about PMS and those types of mood dysregulation issues. And so there was a question that somebody brought in prior to us starting today about how to help treat women who were once on birth control and they want to move away from that and move on, and how do you help with them with that transition. It can be tricky because the hormones underneath have been suppressed for so long. But this is where you can utilize something like neurotransmitter testing to help guide you. You can't necessarily just fix the hormones overnight, but if you have a strong foundation underneath before that OCP is removed by utilizing things like botanicals and nutraceuticals and doing neurotransmitter testing and treating according to that, that can help ease that transition to remove and move away from birth control. So I hope that helps. But something you can be proactive about, I should say, before just kind of stopping them and hoping for the best. Another test that you might want to think about is some type of gut health testing. This is our GI 360, which is an absolutely amazing test. It is, the microbiome, I can't say enough about that, of course, but the microbiome is thought to be, its own endocrine organ. It's that big of a deal for the body. And so when we're thinking about hormone health, we can't really delineate and move away from also thinking about gut health and what's going on there. So this would be an amazing add-on to consider and really be treating in a holistic way. And the gut microbiome, interestingly, it has been implicated in specific pathologies like PCOS and endometriosis. So always something to consider. And then if you're looking to monitor hormone replacement and you've utilized salivary testing, I would repeat that salivary testing 2 to 3 months after consistent use of that hormone replacement, whichever marker that is. You don't have to do the full panel. Usually, again, you can pinpoint the different markers or the different hormones that you've utilized. And then cortisol testing can be a little bit different. That one takes some more time to come back on board, usually 6 months. Unless you're actually using hydrocortisone, then that 3-month window is a good one to keep. If I have patients that are doing really well and we are happy with their hormone levels, we're happy with their metabolism, their symptoms are well controlled, I will still check usually once per year, just to make sure that nothing is escaping and getting out of balance that we are unaware of. Sometimes that can happen, as people age, they might need more hormone, they might need less hormone with time. So that's something I will always do. And then if they have new symptoms or, something else pops up, I'll test sooner than that. But that's the kind of bare minimum that I do. With HUMAP, typically 3 to 6 months after you're doing the first test, depending on, what all you've done, what all you've implemented for as far as treatment, consider doing that retest at 3 to 6 months. And again, you can do, depending on the test and what that looked like, sometimes doing just a section of the test is possible, and you may not need to do the full panel again. So let's move on to treatment ideas. And I'm laying the groundwork here with the first few slides on treatments that are appropriate no matter the age of the patient. So if this is premenopausal, perimenopausal, postmenopausal, these are all going to be helpful. Now, this comes from my background. I studied naturopathic medicine. So if you are a naturopathic doctor, you will appreciate these and find them, very... You've noticed these before. You see them. If this is new to you, it's basically just the tenets of health. If we think about the things that a living being needs to live, these are what they are. So oxygen, hydration, whole foods, avoiding toxins as much as possible. I know we can't do that entirely, but focusing on improving sleep, movement, getting in sunshine, having stress management, and community, right? Not to be overlooked. Sometimes it's easier to think about this in what I call the therapeutic order, meaning start at the bottom and work your way up. A lot of times it's really easy for us to jump in right here because that's just the way our society has kind of focused within the medical field. And I think for people focusing in integrative fields, it can easy to come in with nutraceuticals or botanicals right away, right? But let's not overlook the fact that, hey, is our patient breathing? Are they getting in nice deep breaths and working on that vagal nerve tone on a daily basis? Do they have sleep apnea that's going to be a trigger or an impediment to cure? So going always from the ground up, I think, is a great idea. Sometimes you can't start at the bottom first. You have to come in at the top, maybe with surgery or, a pharmaceutical. That's okay. But don't forget to then go back and start at the bottom and work your way up, because it makes those botanicals and nutrients and whatever supplement or medication you're giving that much more powerful. And it gives that therapy a greater ability to actually have an impact for that patient. So toxin avoidance, BPA and phthalates, these are all considered endocrine disruptors. Certainly pesticides, there's one in particular that's been implicated in endometriosis. So always thinking through this and thinking about, ways to help your patients avoid these things, at least to be aware of them. Household cleaners is probably, big on the list of patients being somewhat unaware of how toxic they can be. And as you know, sometimes it's said that the inside of the house is more toxic than even the outside or living in a city. This was a study that was published in 2018, and they showed that patients who were eating 30 or more plants per week, so different types of plants, had much more diverse gut microbiomes. And we know with more diversity of the gut microbiome, we have greater health, a greater degree of resilience, and less autoimmunity, less pathology. So I share this with my patients. I even have a little magnet that they can put on their fridge and play a game to see how close can they get to this, right? And they can have some competition within their family. When they're keeping track of this, I think it makes it a little bit more easy and makes it within the realm of possibility. And know that, if they have golden delicious apple and the different type of apple, that actually counts as two different plants. So that can be nice. And adding in spices, seeds and nuts, those types of things can really help get them to that, 30 various types per week, because otherwise sometimes they can just be overwhelmed. So this is the steroid pathway handout that I showed you and the cascade that I showed you in the very beginning. But what this is showing you is that we've also given a numerical value for every single enzyme here. So say you do a HUMAP test and you see, hey, this aromatase enzyme, which is actually number 9, is really problematic. It's causing a lot of downstream metabolites that are elevated. And I'd like to be able to target that aromatase enzyme and help my patient out, help to balance their hormones through the metabolism, but also to help improve their symptoms. And the way that we've set this up is that you can look at that numerical value, see which enzyme is, the problem child, and basically go to this chart and find, say, aromatase is number 1, and say, hey, I'd like to calm that enzyme down. So you can use the minus symbol if you'd like to calm that enzyme down. So we're going to down regulate that. Just in case you wanted to increase that, you would use the plus symbol for any of these. So we've highlighted and giving you that information, some of those botanical, lifestyle, nutraceutical options that you can use to target every single enzyme. So I find this very helpful, and I hope you do too. So you can refer back to this. And this is all available for download on the website. And I'm sure we can help you get there and find that, or maybe even send it out so that you have easy access to it. But super, super helpful to target those enzymes. And when you do a test like the HUMAP, you're going to find that once you start doing several of them, that you're coming up at the end of that with very common themes. Depending on, the particular patient, but it's a lot of times it's about down regulating those enzymes that tend to be problematic for people and that tend to cause health issues when they're robust in nature, like aromatase or 5-alpha reductase. Those tend to be enzymes that you don't want a lot of activity with. And then maybe you're upregulating the ones that you do want activity with, which is COMT. That's how the whole system is methylating. Okay. A lot of times we want to upregulate the enzyme called CYP1A1. That actually takes estrogen down the safer pathway, as opposed to CYP1B1, which moves it down the 4-hydroxy pathway, which is thought to be more risky as far as causing DNA damage and causing hormonal problems. A lot of times also you'll see a common theme within the HUMAP of, hey, we want to improve digestion and elimination. We want to improve microbial diversity, increase that. We want to reduce oxidative stress. So you can see that even though the test maybe looks complicated at first, and the test results are, everyone is going to look different, and sometimes it can be a little overwhelming. These are oftentimes the themes that you're going to be coming up with at the end. And so with that, there are some really wonderful natural therapies that, again, are you'll see them repeated over and over and over again when you're trying to, target these certain enzymes. It's usually fruits and vegetables with fiber, a lot of times cruciferous vegetables, right? Increasing diendyl methane, resistance exercise, really any type of exercise, but resistance exercise can be most potent to reduce insulin resistance. Using polyphenols and things like green tea or EGCG, the active component of green tea shows up all over that treatment plan. They're things like you can do so much with green tea and resveratrol, methylated B6, folate, B12 to improve COMT, magnesium, curcumin as an anti-inflammatory. You're going to see that repeated, right? So that can be nice because even though it looks complicated, really in the end, there's some common treatments there that you can utilize. Okay, so let's start going through specifics. When we're talking about PMS, this is obviously a very massive issue in today's world, and what woman doesn't have some degree of this. So conventionally, we're thinking about OCPs or psychotropic meds to treat. Integratively, we might be trying to get a broader look at this. We can help to promote ovulation in PMS with herbs, nutraceuticals, BHRT, or cortisol support, HPA axis support. We can utilize neurotransmitter testing. We can do dietary changes, and a lot of that will be similar to what you saw on the HUMAP, right? So it's all about increasing fruits and vegetables and legumes and dietary fiber, different types of plant materials, regular exercise, stress management, and weight management. Specifically with nutrients, I have always been so impressed, and I've highlighted and bolded the ones that I've found really great clinical impact with. But all of these have research behind them. But I have found it's B6, magnesium, and calcium carbonate, and sometimes along with omega-3s that really do such a wonderful job about reducing the symptoms of PMS, such that, I think patients are also surprised. Like they kind of have come to this acceptance that this is just how it is, and this is how women have to kind of survive and put up with these things while they're living here on planet Earth. But it's really surprising at how impactful these simple vitamins can be. So B6 here should be at the top of your list when you're treating PMS. And most studies are looking at somewhere between 40 and 500 milligrams per day. So it's a pretty broad treatment range there that you can see. And also interesting that this B6 you'll see very intertwined with the neurotransmitters as well. So realize with PMS, we're treating hormones, yes, but we're oftentimes improving other systems within the bodies, definitely the neurotransmitters. Calcium carbonate, I can't say enough about this one either, 1,000 to 1,200 milligrams per day. Remember, it's those higher doses that seem to be more effective for PMS. There was a lower dose that was used in a study, and it showed only non-significantly more effective than placebo. So sometimes it is about that dosing and just getting a little bit more aggressive with that. You can use herbal formulas to help improve ovulation. Sometimes it's about and ovulatory cycles 1 month, ovulatory cycles back and forth that can cause some of this imbalance. And so there are formulas out there that are basically pre-formulated. So if you're not a botanical expert in doing this in your office, you can find those. But this is an example of that, with Formula 1 being used on days 1 through 14 and Formula 2 being used on days 15 to 28. Exercise is definitely any type of movement that the body is going to do is going to be helpful. So if you have a patient that's, splitting hairs, it's like you don't need to worry about that. However, if you do want to help patients decide what type to utilize, remember, resistance exercise seems to be blow everything out of the water as far as insulin resistance and improving blood sugar and improving metabolic health, but it's aerobic exercise that seems to be really helpful for the mental health component of PMS. Strength training was also found to be helpful. So again, it really doesn't, I don't know that we need to split hairs, but I think some of that is interesting and might help your patients to be really motivated, to pick a particular type of exercise. We already talked about neurotransmitters in PMS, but remembering that can have a huge influence. So if you feel, and this would be a good point here, is if you have a woman who's on an oral contraceptive pill, sometimes the hormonal testing is not going to be super helpful for you unless she's planning to move away from that and move to some other type of treatment, because the hormones are going to look low. Their ovulation is suppressed. And then you're also at this clinical challenge where, what do you do with that information? There's not really a lot that you can do. If you give her progesterone, you may decrease the efficacy of that oral contraceptive pill. And if she's using it for contraceptive purposes or even symptomatic control of those symptoms, say like with PMDD, you could be offsetting some of that efficacy. And so you're kind of stuck between a rock and a hard place clinically. Like, there's nothing really that you can do, but you can utilize things like botanicals, nutraceuticals, and neurotransmitter testing. That you can do. So that would be another way to think about that. Okay. Now, if you have a woman with PMS and say she's not on an oral contraceptive pill, certainly utilizing things like actual progesterone is something to consider. And typically, if you just want to make sure the goal of contraception, if she does not desire that, then it can be used days 7 through 28. So basically just taking a break from menses. If she does want to conceive, you want to keep that progesterone supplementation to after ovulation, to the end of the cycle, so as not to mess with that ovulation potential. And there was a question about progesterone topically, like in a cream, versus oral progesterone in a capsule. There's obviously different route of administration there. You will find salivary levels will skyrocket really quickly with progesterone topically. It's very well absorbed. You don't need a lot of it to get those levels up, usually 10 to 20 milligrams, 20 to 30 even. And then for women greater than 150 pounds, usually double that, 40 to 60 milligrams. With oral progesterone, you're going to find that it usually will show low on salivary testing, because 90% of it, once it's swallowed, is being broken down and moving out of the liver, moving out in the urine and the stool. So different pros and cons there. You get greater tissue level with topical in general, unless you ramp up the dose of the oral. With oral, you're getting the benefit of that breakdown through the liver of allopregnanolone stimulating GABA receptors. So can have more of a calming effect, can be used almost as a sleep aid and help women to fall asleep at night. And so there's some differences there. You can choose either, typically in the research, if you're treating postmenopausal women with estrogen and you need to protect the endometrium, it is said that oral does that better than topical. I don't know if I totally agree with that, but if that's what the research says, there's some nuance there. But if you're following that and you want to be diligent about that. It's the oral that's much more well accepted. So let's talk about metabolic syndrome and PCOS. So huge issue that I think we're all facing as clinicians is how to treat this. Metabolic syndrome includes the risk factors of visceral obesity, insulin resistance, elevated triglycerides, reduced HDL, and then hypertension. So there's quite a bit of crossover here. Insulin resistance, you can usually say, hey, we have insulin resistance when you see fasting glucose greater than 99 and some of these other markers, hemoglobin A1C greater than 6.5, and an insulin glucose tolerance test being elevated. However, it's also suggested by fasting glucose greater than 90, a fasting insulin level greater than 9. So you can see this is where I think our testing is very important, because you can get in and treat this before it's well established, which I think is a much more powerful place to be than trying to reverse something that's already, been established. That's still certainly possible, but let's get in as soon as we can. And I know so many patients out there need this because it's just a rampant issue in today's world. Also, remember that elevated salivary testosterone and DHEA is very indicative of insulin resistance. So in males, it's actually the opposite, which is really interesting. Their testosterone levels will start to drop. But if you see elevated salivary testosterone, and especially if it's combined with DHEA in women, think right away insulin resistance, blood glucose intolerance, okay, or blood glucose is elevated. So there's a lot of overlap between insulin resistance, metabolic syndrome, and PCOS. And after menopause, people with PCOS, it's just labeled metabolic syndrome, right? So you can see where there's a lot of overlap. And remember that with diagnosing PCOS, you can really do this when 2 out of the 3 criteria are met: ovulation or anovulation, polycystic ovaries, or clinical or biochemical hyperandrogenemia. So you actually see elevated testosterone, or you have signs and symptoms of that. So remember that polycystic ovaries are not required to make that diagnosis. And that's from the Rotterdam criteria. So in postmenopausal women, we have this strong association between insulin resistance and androgen excess. So in men, it's the opposite, right? In men with insulin resistance, the androgens are reduced. And we start to see that because the ovaries overproduce and start to produce more and more androgen once insulin resistance and metabolic syndrome is an issue. But we know that's not the entire story, because we see androgen excess in postmenopausal women, and their ovaries are not producing. They're usually quiescent at that time. And so we also see that that the total testosterone is bound to sex hormone binding globulin, right? So when we have insulin resistance, it's reducing sex hormone binding globulin, so it's freeing up more and more testosterone. So even though it may be not produced from the ovaries as much, you may have more adrenal output of that. You also have this increase in or reduction in sex hormone binding globulin. So there's less bound up, so there's more available. So it gets to be this kind of cyclical issue that happens. And I think this slide is so nice at explaining all of this, but you kind of have to sit here and stare at it for a while to really comprehend it all. But this will happen in your premenopausal women, your postmenopausal women. And so what we're trying to do is really get in at this insulin resistance area and help that, so that we can stop overproducing insulin, causing elevated androgens, and then this is causing imbalanced hormones. So again, maybe you could argue for the insulin resistance portion, it's really about diet, physical activity, and especially that resistance exercise. I will tell you, there is nothing. I'm type 1 diabetic, and we can all tell you as type 1s that the fastest way to get your blood glucose down is to lift something heavy. So it's much faster than aerobic exercise. And so this is happening for everyone. I just happen to be someone that can tell you, because I can feel it so quickly, how fast that happens. It's that resistance exercise that is so good at pulling excess glucose, burning it off in the muscle, and just getting rid of it. And so it also is sensitizing insulin receptors. And the muscle is very good at that. So just remember that every time you're encouraging exercise. I think exercise can be so hard to start, especially if metabolic syndrome is already in place and this has been happening for a long time. So if you can get them to do something for just a few minutes, they're going to get much more bang for their buck. If they're doing resistance exercising, we're focusing on building muscle or at least maintaining muscle mass. That's going to be the best system to burn off excess glucose and to sensitize the insulin receptors. So conventionally, treatment here is oral contraceptives or spironolactone, metformin, and then Clomid or progesterone or surgical intervention. We can certainly think about this a little bit more broadly where we're trying to really get in on that root cause, right? And get to that insulin resistance, help stabilize blood sugar, support ovulation, which is going to help support symptoms because they're going to have more balanced hormones when that's happening. If we need to encourage weight loss, and as I said, resistance exercise, resistance exercise, resistance exercise. Laboratory testing, I would say, I'm obviously a fan of salivary testing, and part of the reason I like it so much is that I can start to see this climb in testosterone and DHEA far before the serum levels start increasing and far before we're actually going to see insulin levels increase or blood sugar levels increase or that hemoglobin A1C. So I can get in earlier. It's going to be much easier to treat, much easier to motivate my patient and to turn this around before it gets harder and harder. So this is an example of a patient of mine. She was 25 years old at the time. She came in for acne and excess facial hair growth. So obviously, if you hear that, you probably think, I wonder if PCOS is at play or metabolic syndrome of some type, right? So excess androgens in a female. We did the salivary test, and lo and behold, it was kind of the classic presentation of PCOS. So progesterone will be low. Estrogen might be normal or low, and hers was actually low enough it was undetectable by the lab assay. So what this means to me is that definitely ovulation did not happen, at least at the time that she took this test. Whether that's happening every month, is up to you to kind of make that clinical educated guess. But I would say she was pretty far into this type of pattern. And so I would assume this is happening every month, especially given the symptoms. And then we have outright elevated DHEA. And the testosterone, though it's not elevated, you can see it's at the very tip of that reference interval. So certainly upper range. This is just the perfect, non-ovulation with elevated androgens in a young female with acne and facial hair growth, certainly PCOS style, right? So, we can say and argue that no one diet works for everyone, but I certainly would say that 9 times out of 10, higher fiber, higher plant material, getting in more of those fresh greens, leafy greens, and then encouraging, the 30 or more plants per week would be awesome if a patient is motivated and really wants to start doing that, or at least having that as a goal. And then avoiding processed foods, sugars, pasta, breads, rice, things like that. Not that they can't have some of those things, but less, right? And so that's what I encouraged her to do. And then sometimes you might want to talk about, things like conventionally processed dairy, because there's a lot of exogenous hormone within that, and that's certainly going to be an endocrine disruptor. You can also think about inositol. Inositol is part of a phosphoglycan, and it's involved in post-receptor mediated signaling pathways. And this pathway is actually abnormal in PCOS. So we have found that supplementation with inositol, for instance, D-chiroinositol has been shown to decrease serum testosterone and improve ovulation. They were showing that at 1,200 milligrams per day. And then 2 grams of myo-inositol twice per day has been also shown to do the same thing. So you can pick either or. Some supplements out there will have a combination of the two, but that can also be very helpful. Cinnamon, fish oil, chromium, these things are thought to help control blood sugar in more of a metabolic or type 2 diabetes situation. And so certainly a patient doesn't need to do all of these things, but picking and choosing, or maybe finding a formula that has quite a few of these will go a long way. Even if you just start with vitamin D, that can be amazing. Vitamin D has been shown to improve insulin sensitivity in those with metabolic or PCOS and having low vitamin D to begin with. So just giving vitamin D can improve insulin sensitivity. So pretty cool. There are botanical considerations that you can use: fenugreek, milk thistle, and these are thought all to help with insulin resistance. So again, you don't need to use all of them, but considering some of these at least, or a formula that has several of them in there. If you're mostly worried about dyslipidemia and you're wanting to avoid statins, for instance, certainly think about things like niacin or nattokinase, phosphatidylcholine, and those can be helpful to get the cholesterol more in a balanced manner. So again, these are botanicals that can help to promote ovulation. Remember with Joy, she wasn't ovulating, which is why there was such low progesterone and low estrogen for her. So we're trying to use these to stimulate ovulation, and we're using them in a biphasic way. So one formula days 1 through 14, and then a different formula the second half of the cycle. And there are formulas out there, again, that are, pre-done for you. This is an example of one out on the market that is thought to improve ovulation. So they have adaptogenic botanicals and working on that HPOA, so hypothalamic pituitary adrenal, ovarian adrenal axis. You can optimize progesterone and estrogen and the ratio between the two. So making sure someone isn't estrogen dominant and they have enough progesterone. You can do that without using BHRT, certainly. And the idea is like, hey, how do we lower estrogen and how do we increase progesterone? And so I've listed some of the things that can help do that. And mostly, again, I can't say enough of, it's like that diet, that getting 30 or more plants per week and combining that with resistance exercise is very powerful at helping to regulate hormonal balance. And then as cherries on top, as I like to call them, adding in some of these botanicals or nutraceuticals can be helpful. And then those can actually do their job because they're not working against, an inflammatory diet or lack of movement. But this is her follow-up. So this was 8 months after we started this. You can see estradiol has come up to 3.1. We now have a beautiful ovulatory progesterone level at 326. It's a really nice number. And then her testosterone level has dropped as her DHEA has dropped as well. So really, really nice turnaround for her. And this is not the same patient's test, but this would be an example of PCOS within the HUMAP if you're looking at that. So urinary metabolites here, we're seeing some elevated androgens or upper range, so DHEA and testosterone. And then you're seeing some of the metabolites here, upper range. And I'm circling here 5-alpha reductase, because remember, 5-alpha reductase is it's a problematic enzyme. It really can cause a lot of issues. And so if we're targeting 5-alpha reductase, remember, I'm looking at that chart to pinpoint, okay, what enzyme is this? We give it a numerical value. We go to that treatment plan, and we can see that we can downregulate 5-alpha reductase by using the negative symbol here from that treatment document. Saw palmetto, nettles, pygeum, EGCG, which is green tea, progesterone itself, zinc, berberine, or polyunsaturated fatty acids. So all of those have research behind them about reducing this activity of 5-alpha reductase. So part of the treatment plan, along with resistance exercise and diet improvement, might include some of that and be very, very powerful. Okay, endometriosis. I'm going to speed up a little bit here because I need to. We're getting close to the end of time. So obviously, a lot more research needs to go into this field. I think we can all agree as physicians that this is a hard thing to treat and can really just impact someone's life for just in such an extensive way. It takes oftentimes many years before a diagnosis is reached. Really, you need laparoscopy to have the gold standard definitive diagnosis of that. And it's invasive. And so a lot of times that's kind of put off. Conventionally, we're using hormonal therapies to try to dampen down estrogen is usually the main way to do that. And then pain relieving agents, obviously, anti-inflammatory, sometimes even opioids need to be used, or surgery. Integratively, there is some research and more coming out. I hope that, this really takes off and we really get a better understanding of the cause of endometriosis. Omega-3s, NAC, EGCG, and resveratrol have some really interesting research on that. And so that's something I'll always integrate. Sometimes I have a woman who's had a hysterectomy because of endometriosis. I'm still utilizing these integrative treatments to try to be preventative in case there's any endometrial tissue that's been left over. I want to make sure that I'm still targeting the reason that happened in the first place, getting anti-inflammatories in place, and not just assuming, okay, we're done because hysterectomy, right? And it's all golden and it won't be a problem anymore. So remember that perimenopause can last 6 to 13 years, give or take 5 years. So this can be horrible. And we want to be mindful of this, teach our patients about this, let them know that this is a time of a lot of transition in the hormonal system, but it's not something they need to kind of just go, oh, well, I just have to put up with it. Remember that menopause technically is just one day. It's 365 days since the last menstrual period. And then the very next day, they're considered post-menopause. So sometimes that can be confusing for patients. They oftentimes get confused between the terms pre-menopause and perimenopause. But that is the technical definition. And what we're dealing with here is a pretty robust drop in progesterone, and then a slower decline over time in estrogen. So we get a very estrogen dominant, progesterone insufficient type of situation, but then we also get variations in those hormones and then lower hormones just in general. And any degree of any of those can be present. So there's a lot of symptoms that can happen. I oftentimes tell my patients and go through them with them, because I think a lot of times they don't know that they think it's just them. And they go, oh, and it's just so nice for them to not feel like they're crazy and that they're just, this oddball that's suffering with all these things. They're like, oh my gosh, what's wrong with me? Why can't I get my stuff together? Because all of this is literally happening from head to toe. So a lot to go over. And conventionally, hormone replacement, certainly, but you also see out on the market low-dose SSRIs. Even a stellate ganglion block can be used to treat especially vasomotor symptoms, or gabapentin. But integratively, we're thinking a much more, well-rounded, at least in addition to some of these treatments. Stress management, certainly weight loss, dietary modifications is going to be huge, and more of I would argue, BHRT rather than HRT. And then just remember that these hot flashes they can be due to fluctuating hormones. So occasionally you'll find that women have reasonable levels on testing, but they still have a lot of vasomotor symptoms. And so sometimes it is about this fluctuation. With saliva testing, we're doing 4 tubes in one day of saliva, and we're using a pooled tube to gather that information. So hopefully that's cutting out some of that variation that is happening and giving you an actual average of what's going on. And neurotransmitters are definitely involved. This is why there's low-dose SSRIs out on the market to treat hot flashes in women that want to avoid hormone replacement. So we obviously know there's a piece of the neurotransmitters that are affected with declining estrogen levels. So do remember that you have the option of testing their neurotransmitters and utilizing treatments, above and beyond, or maybe away from pharmaceuticals, if that's what you and the patient would like to do. Okay, this was a new pharmaceutical that's out on the market. It's basically an antagonist of a neurokinin-3 receptor, and that's been shown to mitigate menopausal symptoms like hot flashes. It is a pharmaceutical that's tough on the liver, so you have to be careful with this one, but it has just been approved in May of last year. Treating genitourinary symptoms of menopause, this one I think can be, very impactful for women, but I think the great thing is we have a lot of options: estradiol, estriol, testosterone, or DHEA, topically to that the vulvar tissue, or even intravaginally can be very helpful. And remember that low-dose vaginal estrogen is considered safe even in women with a history of hormone receptive positive cancer. So it's pretty well versed, even in conventional systems, that this is certainly something you can consider treatment wise. There's a lot of non-hormonal options. I know there was questions out there about utilizing botanicals and nutraceuticals for treating menopause and vasomotor symptoms. Siberian rhubarb is a very commonly used therapy in Germany. Black cohosh probably has the most research out of anything here and can be quite effective. And maca is also one that can be very effective. So know that hormone replacement is not the only option. I would argue sometimes that the botanicals are going to be probably more impactful in the perimenopausal years. Once you get really close to actual menopause, sometimes they're just not powerful enough, and you really want to consider hormone replacement depending on that person. You can treat by symptom here. So I've laid out, hot flashes, depression, anxiety, and some of the therapeutics that have been most well researched. And I apologize for just kind of going through this, but I hope that is helpful for you for years to come. You can go back to these slides and look at that. One of the biggest things that I wanted to talk about is maca, because it's just been such a wonderful, I think, therapy for a lot of my patients. And most supplements out there, remember, are something called maca or Lepidium myanae, but Lepidium peruvianum is a specific type of maca that has been shown to have the best outcomes for hot flashes. So, not all maca is the same. Some of them are much better, the species, at treating, adrenal fatigue or HP axis dysfunction. So make sure you're choosing the right one if you really want to target, say, like vasomotor symptoms. But this has also been shown to treat low libido, which is wonderful. A lot of women are asking me for something specific for that. So that can be helpful. And remember that estrogen is probably the number one, and I'm sure you'll agree with this, the number one complaint that I have of patients is weight gain, right? They can be sweating, hot flashes, night sweats, horrible symptoms, anxiety, depression, but it's really that weight gain that makes women feel like they're just like, they wake up and they're a different person. They don't recognize themselves, and it's so frustrating for them. So remember, and I will tell them this, estrogen is responsible for keeping fat away from the visceral cavity, right? So it's telling fat to deposit elsewhere. When estrogen starts dropping, there's going to be more fat deposition, especially in the viscera, so around the organs, and it's going to protrude the abdomen and create this belly that was never there before. The body is brilliant. It's creating an endocrine organ to help with aromatization. So it's going to be able to take testosterone and convert it into estrogen and give the body estrogen. I think that's brilliant, but it's also super frustrating. And estrogen replacement has been shown to be able to reverse some of that abdominal adipose deposition. And so just simply explaining that and talking through that with patients can be really helpful and kind of ease their mind that they're not, it makes them feel like they have a little bit more control or a little bit more understanding of what's going on. Even if they don't like it, their body's doing this for a reason. And you do want to consider hormone replacement, not just for symptom control, I would argue, but there is, we have research showing prevention of memory loss, cardiovascular health, improvement in bone health, just anti-aging overall, prevention of even cancer and genitourinary health. But I know this is, it's a hot topic because there's so much kind of confusion out there. But I think the tides are turning. I think patients are getting to the point where they're frustrated enough. They're really demanding to understand these studies that are out there that even we as physicians have a hard time with because they're complicated and there's several of them and we have to know all of them and the pros and cons and all the details, right? So remember, if you're treating vasomotor symptoms, estrogen is a great way to handle that. Patches, I think, are wonderful because they give such a nice stable level of hormone. And if you're doing creams, remember that you can always do half of that dose twice per day to try to get a more stable level. Because with creams, you do tend to have a little bit more of a variation throughout the day. So you can use that twice per day to help mitigate that. Remember to ask your perimenopausal and talk to your perimenopausal patients about this. They will maybe assume that there's no way they can get pregnant because they're in the perimenopausal years, but when you're giving them progesterone, that can increase fertility and libido, and that is a perfect remedy or situation for surprise fertility. So make sure you're talking through this with them and making sure they have a plan in place, because nobody wants to have to deal with that and work through that when it's something that they weren't expecting. Transdermal dosage guidelines are here and things to consider. There was definitely questions about, how to use dosing when you're doing salivary testing. This would be our recommendation and my recommendation. This is what I use very consistently. You can see testosterone here as well. There was a question about that. So treating testosterone in perimenopausal women, you can do that. Typically, you're using a topical cream for that. And then dosing is there. And I would track in saliva. I remember using a topical therapy. I would track in saliva. And you can go and get more details about that with that other Wellness Wednesday that was done in January. So here's a big issue we have. We have a lot of increased health risk when it comes to the menopausal years. Part of that is age, part of that is dropping hormone levels. So we have all of these different things, but the general consensus and the public opinion on hormone replacement, as I'm sure you're well aware when patients come in, is they feel like they're scared of hormones. Hormones drive cancer. We need to avoid estrogen. If we use it, we need to look the lowest dose for the shortest period of time and get off of it, right? It may be they think it drives dementia or drives aging, and they definitely are told to stop it at age 65 sometimes, which can make them very confused. So this is where we need to have longer discussions and delineate the hormone studies that have been done and really make sure patients understand there's very different types of hormones out there. Oral estrogen has been shown just in general to increase inflammation, where transdermal estrogen, we don't see that with it. When combined with progestin in the Women's Health Initiative study, there was a slight increased risk of breast cancer. But also remember, breast cancer, I think, needs and deserves a bigger conversation. Increasing, if we have alcohol consumption or if we're overweight or we have insulin resistance, that actually increases the risk much more than hormone therapy. And so that doesn't get spoken about enough. We have an increased risk with gallbladder disease with oral estrogen, but also those things are increased when you're overweight or there's estrogen dominance at play. And then we have increased risk of endometrial cancer and hyperplasia with estrogen monotherapy if that's not utilized with a progestogen agent. But this is also increased with excess weight as well. So this was a study looking at HRT versus compounded hormone replacement. And I believe this was Premarin that was used. So you can see cardiovascular biomarkers across the board are unfavorable. But with just the change of the type of estrogen, there's a huge difference in these cardiovascular biomarkers. And usually this is not taken into account when we're looking at a study and when the title gets released and patients are reading that, they get a one-liner, right, that estrogen is dangerous. This study was looking at estrogen. So estradiol, not Premarin, but estradiol preserved brain function. Those who started estrogen within a year of menopause and stayed on it preserved their brain activity. And when they stopped, the brain function declined. But if they were on Premarin, it accelerated the brain's metabolic decline. And if the study participants use a progestin and they were using Premarin, their brain function declined even faster. For those that were using estradiol with the progestin, it obliterated the benefit that was usually seen with estradiol alone. So you can start to see the different types of hormones really, really do matter. Okay, we definitely have guidelines for endometrial protection. Anytime you're giving estrogen replacement and the woman still has a uterus, you do have to use at least some type of agent that's either a progestin, that can be even the Mirena, or progesterone. Okay, so we need to remember that. But basically, I will say that the dust has settled when it comes to the information that was kind of first generally released with the WHI, and even so much so that this was the IMS Association, they said that the excessive conservatism engendered by the presentation to the media of the Women's Health Initiative in 2002 has disadvantaged nearly a decade of women who might have missed the therapeutic window to reduce their cardiovascular fracture and dementia risk. So even these larger institutions are saying, hey, like, this is a mistake, and now we have a whole decade of women that have missed the opportunity because of this fear. Okay, so the New York Times published this in early last year, and I think this is just showing you the general societal and women really saying, like, pushing for this, like, something is wrong, I shouldn't be suffering this much. And this article coming out to say that women have been misled about menopause. This article, I highly recommend you go and grab and download it. I believe it's free, but it's called The Contemporary View of Menopausal Hormone Therapy. It's a really amazing review of, and it was just published in March of this year. It tells you all of the details about, the DOPS study, the KEEPS trial, the PEPI study. All of those probably just get garbled in your brain, and you're like, I can't, delineate these away, and you only hear about the Women's Health Initiative study. So this article is talking about the Women's Health Initiative study and showing kind of the faults within it, but also putting into context some of those other studies that are really important that easily, get overlooked, and we stop talking about them because the WHI just overloaded everything. So estrogen is about growth, but oftentimes we have to remember that it's about growth or controlled growth. It's also considered a trophic hormone. This is the Latin derivative to nourish. And estrogen has over 400 functions in the body. It maybe gets a bad rap sometimes, but I think this was a mistake, to interpret some of the research. Estrogen receptor alpha is about growth. Estrogen receptor beta is about controlled growth. It's really the balance. And the way that you can accomplish that is by giving, say, a biased formulation. So you have estradiol, which is mostly it's like 50-50 alpha beta. Estrone is mostly alpha, estrogen receptor alpha. We don't really give that anymore. We used to, not anymore. And then estriol is mostly beta. So this is a natural way that you can provide a very well-rounded approach. And you can utilize the estrogen quotient, which is provided on the salivary test, to determine if there's enough estriol in comparison to the more, a little bit more proliferative E1 and E2. Okay. This was a study that was published in April 9th of this year, and it's looking at hormone use beyond 65 years. And basically what this says, I know there's a question about this, like how long do you use hormone replacement? A lot of patients have that question. A lot of times other providers are telling them to stop at age 65, but they're showing that estrogen beyond using just, far beyond age 65 was associated with just overall decrease in mortality, decreased risk in breast cancer, lung cancer, colorectal cancer, congestive heart failure, strokes, atrial fibrillation, heart attacks, dementia. I mean, it's overwhelmingly beneficial to the majority of women to continue on indefinitely, far beyond the age of 65. Now, this is somewhat controversial topic, the window of critical timing window. And it's basically saying that it seems that when you start hormone replacement closer to menopause, those women have a better outcome than if you started later. And there are some studies that even say starting like 10 years after menopause can actually be damaging. I think most of those studies were using things like Premarin and progestin, but it is something you want to be mindful of and not just give hormone replacement to everyone, but be a little bit careful about that. Now, something I really wanted to focus on today, and I know we're over on time, so I apologize here, but this is tachyphylaxis, and basically it's rapid protection. We know that if we give a lot of hormone or too much medication, or we give medication continuously, the body is smart and it's going to start downregulating and desensitizing the receptors. So we see this issue with hormone replacement. We see it with things like albuterol inhalers or nicotine, right? And I think it's overlooked in the hormone category. But even the British Menopause Society has come out to say, hey, we're aware that there's a lot of people being given massive amounts of hormone. And so we want to be mindful of that. And we start to see things like anxiety and depression when there's too much hormone given. And this is really my kind of personal thing here is I just feel like so many women coming into my practice are given these massive amounts of hormone. A lot of times it's because they're giving transdermal therapies and it's being tracked in serum. But this is an example of just a published article on this happening with pellets. It's quite common with pellets. The dosing can be quite high, not always, but a lot of times very high. And so basically what I just want to say is that there is research showing that if you have a lot of hormone or you have a lot of hormone and the body's never given a break, that the receptor sites can downregulate. And this isn't just a theoretical thing. We have this showing in some studies. In fact, continuous exposure resulted in this study in refractoriness. So meaning there was just less response. When they did brief pulses of estrogen or a lower concentration but prolonged stimulation, they saw better results. So that the estrogen seemed to be doing its activity and making sensitive tissues and actually having a benefit to the body. They also noted when the massive doses were given, the estrogen receptors downregulate and they're very slow to replenish, so that large doses of estrogen actually deprived the uterus of these receptors. Now, this was an animal study, but I highly suspect, I think it was in sheep, that this is happening in women as well. So thus, my argument for not giving too much estrogen, and if you're giving too much estrogen, sometimes you'll notice there are signs and symptoms that happen with that: vaginal bleeding or headaches, depression, hot sweats, hot flashes or night sweats. Basically what this looks like, besides the vaginal bleeding and breast tenderness, is that it almost looks like low estrogen, right? So if you have a woman on high amounts of estrogen, but she has low estrogen symptoms, think about this, and maybe the dose is just simply too high. Okay, so this is, again, why I like to use testing, because I don't like guessing, and those symptoms can be so tricky to figure out if you're just taking in the subjective information. So remember that you can, rely on the testing for that. You can use any type of medium as your baseline testing, but I would really argue that serum and urine are going to grossly underestimate transdermal doses, and it's going to overestimate oral delivery. I tend to use saliva to track my dosages, but I'm using urine to track how it's metabolizing in what direction. So I hope that's helpful for you. Please remember to just, listen to your patients. Don't forget to do that, because sometimes we can get, I think, so worked up and focused on the black and white numbers that we have to kind of take a step back and think, okay, is this making sense? Is it making sense with the timing and the symptoms? And that, we do have the risk of creating tachyphylaxis and having the receptors deprived of estrogen if we're giving too much hormone, and that can happen with any of the hormones. So follow the therapeutic order to reach hormone homeostasis. You want to utilize multiple therapies like hormone replacement, but also look at diet and lifestyle, nutraceuticals, and botanicals. The hormone levels matter, yes, but also the receptor site sensitivity and the influence of endocrine disruptors. So we want to kind of move away from this fear of hormone replacement and think a little bit more critically about each one of these studies that we have available to look at. And then remember, you have these kind of hijackers, so inflammation and stress and poor sleep, and we want to take that into account. And then we're utilizing the testing to get objective measurement, so we don't have to just rely on those tricky symptomatic presentations. So thank you so much. I'm sorry I went over, but there it is, and I hope that was helpful for you all.